Oh, thank you, Taylor, and thank you so much, Pinky. That was really informative. And I have to say that urinary issues are always a very difficult topic to tackle in Parkinson's patients, and that I'd have to confess, many of us neurologists, including movement disorders specialists, are not really that well versed in tackling urinary issues in Parkinson's. So I just have a few questions here that were submitted beforehand, and some of them are really interesting, and some are quite intriguing. One of the things you just mentioned was avoid just in case peeing. Does that apply also to going to the bathroom before you sleep?
So, by just in case being, we mean that during the daytime. The nighttime is a planned activity. We know that, ideally we'd like to sleep during the course of the night. Most people have had dinner approximately 3 hours or 4 hours before bedtime. And so it's good to empty the bladder so that would count as planned peeing rather than just in case. Just in case is that we've gone use the bathroom and then we are planning to leave the house, or we just see a bathroom on the way and we say, okay, well, let's just use it. But then the bladder doesn't get trained to store. Now, suppose we know we are going to be out of the house for 2 hours or a long drive, and we may not have access to a bathroom. Then yes, definitely we should use the restroom, even if it's not 2 hours since last void, because then that's again planning. But just in case is, oh, I'm crossing, there's a bathroom there, let me just use it, because who knows if I might need to just go again. So if we have access to a bathroom, we want to go every 2 hours. But if we don't know whether we'll have access to a bathroom within the next 2 hours, then it makes sense to use it before that.
Yeah. Well, what is your feel about the frequency of urinary issues in men versus women with Parkinson's? Who do you think is more prone to urinary issues?
I see it in both. I think it's a little easier for women to, for again, there are coexisting issues, right? For women, there have been childbirth issues, hormonal issues, which can make the pelvic floor a little bit lax. For men, there can be some prostate issues. So a lot really depends on what the coexisting conditions are. So I see it in both. I think for women, sometimes it's a little easier for them to use protection. And so they can, they're a little bit more liable to use protection. And so it sometimes becomes less of an issue. For men, sometimes they're not so used to using protection. They're a little bit hesitant to use it. So it can sometimes, even though the frequency might be the same, it becomes a little bit of a bigger hassle to them.
And then for your male patients with Parkinson's with urinary issues, especially those with overactive bladder or going to the bathroom frequently during the day or during the evening, do you routinely send these patients to the urologist for workup for benign prostatic hypertrophy or enlargement of their prostate? Is that something that we should routinely do?
So what I do is I ask my patients whether during their last primary physical, whether they had a prostate exam, or if they have an annual, tell them that can you have your primary do a prostate check. And if they said, yes, it was checked, or my primary routinely checks my prostate, then I don't necessarily send to the urologist. Or I'll just have them ask your primary whether you need to see a urologist to get the prostate checked. And if the primary is comfortable just monitoring the prostate, they don't have to see a urologist. Because there can be specialist overburden too, like how many specialists do you see, and there's problems commuting, etc. So if the primary is keeping an eye on the prostate, then I don't send to the urologist. But if the primary detects that, yes, there is a prostate issue, and now the overactive bladder is increasing, then I'll typically get the urologist involved.
Yeah. And then, one of the things that was a great take home for me from your talk is the pelvic exercises and Kegel. it's been a while since I've thought about these exercises and their existence. And are you aware of physical therapists that are really specialized in doing this? I mean, most of the time I just send my patients to general physical therapists that do big and loud, and I say, they're experts in Parkinson's. But the honest truth is, I have yet to think of one therapist that I work with that says, "Yep, I kind of can help their patients with urinary issues in Parkinson's." So are they difficult to find?
Yeah, so actually the slides that I showed were from Amy Talk, and they are physical therapists who actually run a pelvic floor clinic.
Really?
And typically what happens is that the therapists are also treating women after pregnancy. So, they end up with us. So they're seeing women after delivery who are having bladder issues. And then that's how their interest started in the first place. And then they become so much of a specialist in bladder issues that they start treating people with bladder conditions, with MS or with Parkinson's disease. So pelvic floor they tend also to have a little ultrasound machine where they can see if patients have like bladder retention.
Yeah.
So, and a lot is, suppose even if there are centers that don't have pelvic floor kind of specialists, which is the typical norm, even in those patients, if they just see a therapist who works on core strength, there can be a lot of duplication of the muscles that are strengthened. So it's still worth seeing a physical therapist for core strength building.
Yeah. And then, one of the more common things that I see in my Parkinson's patients that I always suspect, especially if they get confused, their Parkinson's seems to be worse and there's no good explanation for it, will be urinary tract infections. So do you think that Parkinson's patients are more prone to developing UTIs?
So, just with time, people become more prone to urinary tract infection. That also tends to be sort of the same age. So as in women, hormonal levels fall, the mucosal plug becomes a little less dense. So it's possible for bacteria to climb. And then as people do start using protection, that also can sometimes make people more prone to urinary tract infection. So, and with Parkinson's, if there are mobility issues, and sometimes people will dehydrate themselves. So if someone's thinking, oh, I might be off, or, I may have a hard time going to the bathroom, I don't have help right now, they may just dehydrate themselves. And if you dehydrate yourself, yes, that makes people more prone to UTI. So having Parkinson's, yes, it may make people more prone to UTI in indirect fashions. And and you were right that if someone calls and says, oh, or a spouse calls saying, oh, my significant other or whatever is more confused, or but last 2-3 days have been very bad, and is confused and hallucinating, even in the absence of fever, or even if the urine is not smelling or looking any different, it's always worth checking for urinary tract infection. And sometimes, it's possible to buy these home dipsticks.
Oh, yeah. They're easy,
in
right?
the clinic. You can buy them over the counter. So it could be handy having some of those in the clinic and just having those at home and check if there's some flaw, a big infection, it'll show up on the dipstick.
Yeah. Many of my patients who tend to go to the bathroom a lot, either during the day or during the night, tend to hydrate themselves because they're afraid to go to the bathroom, right? And so many of my patients end up having either dehydration and drops in blood pressure, or as you just mentioned, they become more prone to urinary tract infections. So it's kind of a difficult balance of having too much fluids and too little fluids. Do you have any game plans on how to make it a win-win, given that these are two opposing things?
Right. So it's reflex that people think, well, if I don't drink, then I'm not going to go. So that takes care of the problem. But
but most of our blood is made from water, right? And our
Right.
organs, so much of our body is just made of water that we cannot dehydrate ourselves, because then there'll be drop in blood pressure, we'll get dizzy, we'll fall. So we have to hydrate. Now, the way to hydrate smartly is to hydrate from the time you wake up
Right.
to about 4 hours before bedtime. So about 4 hours before bedtime. After that is just sips of water. It's not like cups of water. So the 6 to 8 hours, the 6 to 8 cups of water has to be from whenever, like 6 or 7, 8 a.m. till approximately 6 p.m., which is when most people are starting to wind down for the night. Avoid a glass of wine at night because that will irritate the bladder. Avoid caffeine in the evening, which will keep you up and will irritate the bladder. And then during the daytime, when you are hydrating, try every 2 hours to be approximately every 2 hours to be using the bathroom. And sometimes the way to keep an eye on the hydration is that every time you have a meal, and if you are taking Parkinson's meds, at a minimum, they tend to be 3 times a day, generally, at a minimum. So every time you take your pills, instead of with a sip of water, have it with a cup of water. So if you have a cup of water with your pills and a cup of water with every meal, that generally is enough. And then if you have any pills to take at bedtime, that needs to be just with a sip of water, not a cup of water.
And then if they wake up in the middle of the night to go to the bathroom, do you encourage them to drink a little fluids
Just a
or?
sip, just a sip, because the mouth can be dry. So have a little sip of water, but not a full glass full, because otherwise 2 hours later,
Exactly, right? Right. It's a
they'll be
vicious
up
cycle.
again. Right.
Absolutely. Yeah. And what is your experience with the Parkinson's medicines in terms of their effect on this overactive bladder and frequency of urination and nocturia or going to the bathroom at night? What is your experience?
So, the data is all mixed. Some have noted that, yes, if you optimize with carbidopa, levodopa, there
Mhm.
will be a little less of the overactive bladder, like the detrusor muscle, the bladder muscle that just keeps contracting. Sometimes it will settle down. But DBS also mixed picture. So it can help. Optimizing can help, but it may not do enough. That is why one may still need these other options, and the bladder and the exercise definitely is the best. Core strength is the best. Optimized PD dosing is good, may or may not be enough. But if your PD meds are optimized, you can likely exercise better, maintain your core strength better. When you go to the bathroom, you're able to likely make it walking at a comfortable pace rather than trying to rush. And also, it does help to have clothing that's easy to slip off and slip on. So avoid like buckles and too many hard zippers or buttons. Better to have easy pull up, pull down so that you're not
Mhm.
rushing, and it's just less hassle for everyone. And whenever you're outside, try to keep a little water with you. Commonest problem I A lot of people have a lot of juices, and most people are used to having orange juice first thing in the morning, and they tend to have a lot of tomatoes. We get tomatoes in
Sure.
lots of forms, like pasta sauce, and tomatoes are in everything. Tomatoes are
Sure.
irritating to the bladder, so just limit some of that citrus intake.
And then our patients with more advanced Parkinson's, one of the hallmark of more advanced disease would be the fluctuations, right? And we usually talk about motor fluctuations. In other words, when their medicines start to wear off, their levodopa starts to wear off, they get slower, they get more rigid, they have more tremors, and so on and so forth. But is there such a thing as non-motor fluctuations involving urinary symptoms?
Non-motor, there's not per se defined that I know of non-motor, but during non-motor, people will, even during the motor off, or even the sub, when they are not entirely on, mobility decreases. And due to that, people will have more accidents when they're off, just because mechanically they cannot make it to the bathroom.
Yeah.
but there's not a clear-cut non-motor, and sometimes during an off episode, but it's hard sometimes to capture the frequency to that level of precision, like whether it's noted to the on or the off. So in general, if motor symptoms are well optimized, bladder will do better. There are more chances, reports of leakages during an off episode.
And then, can you recommend, or are you aware of any supplements that are good for urinary health for Parkinson's patients in general, or just for the general population?
The general population, when I refer my patients to urologists, sometimes I've seen them prescribe azo, and sometimes some patients who've been prone to several bacterial infections, sometimes there's like different strands of cranberry
Right.
that are prescribed. Those are the only ones that I know. Sometimes regular urinary infections. Some people will get put on like antibiotics, like sometimes even long term. But in terms of supplements, I've only seen, and sometimes actually, if just treating constipation well, if one is very constipated, because it's in the same area that can impact the straining, if one regularly impacts the pelvic floor health. So it's really important not to be straining when one is going using the bowel, one is trying to have a bowel movement. So again, the hydration helps with that. Stool softener is very helpful.
Sure.
Senna is helpful. Miralax can be helpful for the constipation. And sometimes what happens is people will have a good bowel movement and then they'll just stop everything. And then, they'll get caught in the same thing. And then 2-3 days later, then they have to strain and they use everything. It's very important to use the stool softeners or the fibers on an everyday basis so that you're not backed up. Aim for a bowel movement every day, max every 2 days. If you go longer than that, stool becomes hard. Then you have to strain. If you strain, then that affects the pelvic floor, and that also will cause a bladder issue.
Right. So the Kegel maneuver, does that apply both to men and women, or is it more doable for women versus men?
Those because ever since childbirth and post and pre, they talked about Kegels, but actually the pelvic floor exists for both, and Kegels can help in both men and.
Got it. Okay. And then, there's more and more interest in prodromal Parkinson's, especially with the advent of the skin biopsy for alpha-synuclein. Now we're able to make the diagnosis, earlier and earlier. And in fact, we're catching patients even before the first motor symptom of Parkinson's comes out. So most of these patients just have dream acting, their sense of smell may be impaired, they may have mood changes. And there's a question here about in prodromal Parkinson's, do they start to have urinary issues as well that you're aware of?
So most of the literature that I've reviewed is, the constipation we know can be prodromal, but the bladder symptoms tend to be actually further down. So they tend to mostly appear after motor symptoms, a few years after motor symptoms. Now, again, age plays a big impact because just with age, bladder control goes down. So we don't know if it as a specific prodromal symptom, mostly a few years after onset of motor symptoms.
Yeah, and then one of the things that stuck in my mind in your talk is that importance to differentiate between Parkinson's and MSA, multiple system atrophy. Would you think that MSA patients probably would have more prominent urinary issues like incontinence, maybe, much earlier than the Parkinson's population, and possibly even have it in the prodromal stage?
of symptoms. One is overactive bladder, like
Right.
there's too much, like urinary urgency, have to go more often, or it's the other way, where you can't go, which is
Right.
kind of how the prostate presents. Now, in patients with MSA, it's more of the hesitancy rather than the urgency. So if some, and in Parkinson's, it's atypical to have bladder retention. So typically, how bladder retention is, when empties the, has a void, and right after they empty the bladder, you go and use an ultrasound machine, and you
Right.
see how much urine is left in the bladder. In Parkinson's, typically you will not see much retention, but in MSA or multiple systems atrophy, there will often be post-void residual volume that's more than 30 or 50 cc's. And so in those patients, typically done prostate surgery, it has led to further complications and not enough benefit. So that is why the important. Now there is a particular way to diagnose. You can do an EMG of the sphincter of the urethral sphincter, and that has a particular different signal in Parkinson's or in MSA. It's not typically an EMG test that's performed. Most of the time, we are diagnosing the MSA clinically, and then we are treating. We have to, if someone is already having retention, like in MSA, and
Sure.
then you treat it with these overactive bladder medications, they'll get backed up even more. So one of the, sometimes by history, or if we do the bladder ultrasound and we are finding that there's some backup, then we definitely get the urologist involved. Rarely Parkinson's exception.
Yeah, one of the things that I do whenever there's some questions, especially in the early stages where MSA and Parkinson's can overlap, and in fact, many MSA patients can present very much like Parkinson's, and some of them can even be levodopa responsive, quote unquote, right? Except that the levodopa responsiveness is not enduring, and that after a few months or maybe a few years, but definitely not more than 5 years, many of these patients, if not all of them, will lose their response to levodopa. So I usually do an autonomic study. If in doubt, for many of my suspected MSA patients, I really don't expect a lot of autonomic dysfunction in the early stages of Parkinson's, as you just mentioned. Whereas in MSA, it seems to be very, very prominent. And then I think there's also some talk about the possibility of differentiating MSA and Parkinson's through the skin biopsy. Both can be positive for alpha-synuclein, phosphorylated alpha-synuclein, but I think the distribution of the alpha-synuclein in the skin biopsy can be different. In MSA, it tends to be in the so-called subepidermal plexus, which is right beneath the epidermis. That's where the concentration of the alpha-synuclein is. Whereas in Parkinson's patients, it's in the deeper layer in the autonomic, nerves in the dermis, which is beneath the epidermis. So, and again, I echo what you just said about the prominence of this urinary symptoms in MSA patients, especially in the early stages. What about deep brain stimulation? In your experience, under your set of patients, do the urinary issues tend to improve more, or remain the same, or worsen after DBS?
I found that for most of my patients, it does seem to improve. Overall, the nighttime sleep improves because they're not wearing off at night. Now, what will happen is if they're lying awake, tossing, turning, not off, even a little bit of they'll go to the bathroom. But if they are sort of deeper in sleep because now they're not off, generally that bladder signal will need to be a lot more strong for them to get up and go to the bathroom. So in general, I find that when the off time improves, as it generally does with after deep brain stimulation, their bladder does tend to do better.
Yeah. I've heard anecdotally. Again, I don't have a good study to back this up, but anecdotally, I've had many patients that are on polypharmacy, different drugs, two or three, sometimes even more for their Parkinson's. And then my goal for DBS is to really reduce the doses of medicines, and the ultimate goal is zero if possible. And that's more commonly occurring in patients that have earlier rather than super late DBS in the course of the disease. So I've heard many of my patients say that their urinary symptoms, including the overactive bladder symptoms, tend to improve. It makes me wonder whether the motor fluctuations have to do with, something to do with that versus maybe some of the medicines themselves are probably contributing. Like for instance, anticholinergic drugs, I would say, including maybe amantadine, which we use a lot for dyskinesias, will probably favor urinary retention and difficulty urinating. Do you share the same experience?
Yeah, so, and then just the Phenadil, sometimes some patients will need it if they're young patients in work, they're having a lot of tremor, and that causes a of mouth, some confusion. So both that and amantadine, we can drop the doses of those after DBS. So that helps too with bladder hesitancy problems.
Right. And then one last question I have here is dementia. Do you think the urinary issues are more common, like incontinence in demented Parkinson's patients, or it really doesn't matter whether they're demented or not?
So it's a complex issue. What happens is that, yes, dementia, just the stage at which it happens, the bladder problems tend to come along with it. However, there's even a further interesting caveat that when we use procholinergic medications such as, say, donepezil or rivastigmine for affects the bladder too. And there are reports that patients who started memory medications sometimes urgency. Because they are sort of like the opposite of your oxybutyl detrol kind of agents. And then sometimes, so we keep an eye when we start medications for dementia, if we see lower the dose, and they'll have a little improvement in their overactive